Just go into the microphone. There's 2 microphones, so we can hand them around if you want. Identify who you are.
So my question.
I guess you have to turn it on. Turn it on. These ones you have to turn them on.
My question for Dr. Ravi, thank you very much for the extensive, thorough review. And do you have any experience, any difference in efficacy between the doxorubicin infusion, like over 3 days, over the bolus doxo? Maybe the tumor will expose like more time to the chemotherapy than the bolus, because our here practice to give boluses of doxorubicin over like 2 days. But do you have any difference in effectiveness?
So a couple of things. So I think there's a pediatric paper that came out from our group that actually compared the infusional approach with the bolus approach with use of xenocard or dexrazoxane as a cardioprotective agent to look at both cardiac toxicity and any effects from reduced effectiveness. Bolus is easy to give and is also produces less mucositis, and that's why it's so attractive, especially in my older patient population. We generally tend to use only bolus, not the infusional one, but we give it along with the cardioprotective agent, xenocard. The study didn't show a difference in terms of it is certainly not inferior compared to the 3-day infusional approach. It's kind of interesting to see that if you actually look at nanoparticle delivery like liposomal doxorubicin, which actually even further extends out the delivery of the doxorubicin over a much longer period of time, doesn't necessarily produce superior outcomes in cardiac or soft tissue sarcomas anywhere else. I think Brian has some data that's all set up to come out, which also looks at this very same issue. But I think it's fair to say that the bolus administration with xenocard is a very safe and effective way to treat these tumors. Albie, I don't know if you...
I think we agree. The person who asked is Ismail, one of our fellows. So I think he's just seeing whether there's a different way of doing it. So that's exactly what we do in clinic anyway.
Another question?
So this is Brian Van Tine from WashU. I just think that I saw something spectacular this morning, and I think I'm throwing something out rather early for this conference, but this 3D reconstruction of imaging is unbelievable. I mean, I think this is like really, really neat. And one of the things that I think, in terms of international collaboration to consider is that as these tumors are resected, that 3D modeling can be used against these new nanostring platforms that allow you to look at 3 or 4 cells and 1,600 genes to really begin to understand the temporal dynamics, because like single-cell RNA-seq just kind of tells you how many clones are there, and it's kind of useless. But since you have this ability to say, what's here, what's there, what's here, against what's in the stroma and what it's doing at the same time, I think this kind of integrative thing where we actually start with the imaging and start with these models and then build out from there is just fascinating. And I'm sorry I'm giving more of a speech than a question, but that was just really cool and I wanted to say so.
Yeah, Robin Jones, Royal Marsden. I'd agree with that. The sort of the range of your presentations are just fantastic with the imaging, looking at the sort of macroscopic picture, but also I'll be moving into the microscopic domain in terms of monitoring for minimal residual disease is the way forward. And the other thing is the sort of treatment philosophy. I think, as we spoke earlier on, the UK is very conservative in terms of using neoadjuvant chemotherapy for soft tissue sarcomas in general. But I think for cardiac sarcomas, we're all on the same page in terms of that these are systemic diseases, and we really need to work on improving our approach to systemic therapy for cardiac sarcomas in general.
can panelists ask
Yes,
questions to each other?
absolutely.
So I agree with Brian that the three-dimensional imaging, its utility in the preoperative evaluation and getting the surgical team up to speed is just unquestionable. But I also want to call out to us medical oncologists in the room. Decision making the way we do it is using these 2D images and 1 diameter measurement of these particular tumors, which has got so many layers of complexity. The density changes, the vascularity changes as mapped by the contrast flowing through the tumor, the volume changes, the rotation that happens from scan to scan, etc., makes our evaluation really a challenge. Which currently, at least in the RECIST way of measuring tumors, you just take the longest diameter and call it a response or a stable disease. So I do think there is a huge potential, untapped potential not for the cases that are showing shrinkage on 2D imaging, but there's a lot of cases where we kind of label as stable disease. You give chemotherapy 2 cycles, looks about the same, right? That particular patient population where we don't see much in the way of change on our traditional imaging, the use of 3D rendering and the ability to interact with the target tissue I thought that haptic feedback and the mechanical feedback is really interesting. It would be nice and a lot more cool in clinic to be able to put on your goggles and handle the tumor before and after chemotherapy in both looking at it, understanding it in a 3-dimensional sense. Because I think the unidimensional measurement of a 2D slice came into being primarily to reduce variability from person to person. Our brain is really capable of taking in 3-dimensional images. So its use in the medical oncology clinic, for example, to evaluate how response is going with additional dimensions like Brian was talking about, or even including glucose consumption or density of the tumor as measured by, or vascularity of the tumor changes, really puts us in a place where we can evaluate these tumors in a much more multidimensional way than what we have traditionally done. So is there any effort that is happening in terms of serially looking at these particular tumors? How labor intensive is it to really do this in practice? Would there be an opportunity for this?
So in the context of tumors, I wasn't able to find anything that was published specifically in terms of specific case reports, just mentions of it here and there that works like this was being done. But techniques that have been used, for example, in aortic disease, to actually map the blood velocity. So you can actually create a 3D model of the aorta, and you can see the blood vortices inside the volume. So you're able to actually create and print and generate those models. And those techniques could easily be applied to map vascularity, variations in density, variations in response, to give you sort of a real 3D map and 3D calculations and volume measurements and mean density measurements and so on. And if you have enough of a database of these cases that have been modeled, where you have a image-based model, then you have pathologic-based data, you can over time learn to recognize image findings that correlate with mechanical properties and other findings in the modeling. But again, the big limitation is the numbers of cases. And I think having a database internationally, if that includes 3D models and imaging data and sort of post-resection pathology data on the models, that would be the step forward. Because the techniques are there for doing it.
I think this is particularly important because since the 90s, I don't think we have really innovated how we measure, at least from a med-onc assessment standpoint. I am fully aware of RSNA's efforts on volumetrics and all of this, radiomic data feed that is coming in. While these are real and the whole segmentation algorithms are available to, really interfacing them into the practice becomes a real challenge. So they do all of this fancy stuff and have 70, 80 parameters come off the tumor, and then when it comes to delivering care to the patient, I'll say, oh, it's 4.3 centimeters in longest dimension, and that's what Albie and me use in order to decide whether to keep going or not. So everything else, all the other 58 other attributes that were extracted, never go into the treatment planning aspect. So I think it'll be really cool if in this particular area where clear segmenting algorithms have already been developed, if we can take that feed and start correlating it with overall response or overall survival of the patient as to which of these parameters. Does density even matter? Does the amount of necrosis really matter? Can a medical oncologist not just measure it by size, but explore into the tumor and see the necrotic areas? What is the difference between two particular time points in measurement? Could be quite transformative. So, and I know Toronto has a very strong background in developing automated workflows for these sort of things as well. So it's a real opportunity for UHN to really push and be a leader in this particular area, I think.
Your comments highlighted a really important issue about where the bottleneck is. Because right now the bottleneck is not so much in the conceptual development of the techniques, it's really in the clinical translation of it, which is heavily limited by the situation where you have, it's a situation that you have multiple technologies from different vendors, and the difficulties in getting bits to interact with each other really takes up a disproportionate amount of our effort. So the techniques that we're actually bringing to clinical use now are 15, 20 years old. And if the vendors were sort of more cooperative, we would have been able to actually bring these to clinical practice much earlier. So much of what you described was providing those measurements, so the software on the PACS is able to develop those measurements, but that software doesn't talk with the reporting software, or it's inconvenient enough that the radiologists don't want to spend the time to summarize it, and not enough work has gone into the user interfacing of these technologies, both for the immediate human user, but also the interfacing of the technologies with each other to allow things to talk to each other. So in the cardiac OR, this is a constant problem for us. We're dealing with multiple machines and monitors. So for example, in echocardiography, if you're interpreting an echo image, it's extremely useful to know what the blood pressure was when the heart was functioning this way. But we cannot get the arterial line trace on the echo image, right? It's just a simple thing. And that just has not been possible, even though I've spent 4 years trying to work on that. So that's it. So I have a few RNA societies, so supporting efforts at standardization and developing technology standards is a major advancement.
You can see why I put the 3D model as the poster of the poster, because it's so new, so innovative, so novel, and so helpful in so many different ways. I think it's great. I was going to ask one question. I noticed some questions. I'm going to sneak a little question in there. We use PET scanning to look for metastatic disease now. Is the software able to take properties of the primary tumor and look elsewhere in the body for that and mark those for you? Or does it have to be done by hand in contiguous structures?
I think any value that can be quantified radiologically, you can easily program a software that maps it. Again, the limitation would be the extent to which you have access to the back end of the software from that vendor.
So theoretically,
but anything that can be seen can be modeled.
So theoretically, we could theoretically take a PET scan, for instance, and compare it to a 3D model with your software and see whether or not it's how accurate it is against the gold standard. More questions from the audience? You try to use the microphone, just so, who's got the microphone? Oh, it's right there.
One of the things, and that's what's so wonderful about this meeting, is the importance of international collaboration with extremely rare tumours like this. Is the moving forward is this sort of standardisation of novel imaging techniques, because I suppose in a way PET, as you say, is very useful in terms of detecting metastatic disease, but in terms of evaluating response to systemic therapy, it's still very challenging to know what a decrease in SUV max really means. And I think with the introduction of novel modalities, it's really important that we work together to make sure that these techniques are standardized and validated and are reproducible. So I really value your thoughts on that comment.
Yeah, so this is I think Scott Schutze has done some work in this particular area, and we've demonstrated in our data set as well. But in PET, you need a substantial decline in SUV max in being able to really correlate it with outcomes that we really truly care about. So we find that at least a drop in SUV max by 40% or larger to correlate with survival, actual difference in survival in many patients. So what do you do in the other 0 to 40% decline? I don't know. But when there is a very dramatic dropout of signal with chemotherapy, it does translate into an overall survival implication in the metastatic setting when we have looked at it. But it requires a very substantial dropout. And it's also histology dependent, because in angios, when we were able to demonstrate that difference, when we translated the same model into Lyos, we got it just totally broke. Even in the cases where there was a 40% decline, it didn't translate into overall survival. This again comes back into the area where it is so critical. I mean, we can argue about whether it is useful or not. Integrating this data at a global scale and being able to look at it with numbers that are reasonably large is absolutely necessary.
But I suppose one of the things with PET, Scott, of course, worked with Janet Erie and Dave Mankoff. Just doing a PET study in a common tumor type like breast cancer at different sites is so challenging to get every piece in place. And I tease Janet sometimes about we need to do, for this trial, we need to do 2 PET scans on the same day just to make sure that everything is calibrated correctly. And you go, how can that be a practical approach? It's so time consuming. And as I say, I suppose the fundamental question is what does a drop in a SUV max actually mean? And I take your point. The sort of retrospective studies that have been published are very interesting and thought-provoking. But I suppose we need to sort of move forward with prospective data collection.
Validation.
Yeah.
No,
It seems I'm being a little bit contrary, but
no, I think that's a very valid point. I mean, any signal that we see in the retrospective setting, to push it forwards into the prospective arena is something that we should do, given unlimited resources. So if there is a funding interest in any of the participants in here in moving it forwards, we're more than happy to actually incorporate. But you bring up a very good point. The protocol with which the PET is being done is very critical. If the patient waits with the radiopharm in them for too long and you repeat the scan, you can get a 40% drop in activity just from the time point from which you actually did the study, which is why we do not use PETs from outside our institution, and we try to stick with our standard protocol, and we are very, very timeline dependent in terms of acquiring images. Because if you don't do that, then you cannot demonstrate the value in any shape or form, and that makes it quite challenging. So, but that's an incredibly important point, because if you've got multiple centers with different protocols of administration, the drop-off across different centers may not necessarily equate to the same things when you try to translate it with outcomes that you're interested in.
And in a way, it's such a pity, because there are publications on PET and sarcoma going back to the late 1980s, early 1990s.
So sorry to go back to this imaging, but I just think it's cool. And for a metabolism person, the PET thing is causing me to stroke just because of what it actually measures. It's only a measure of glucose uptake. It has nothing to do with anything besides that. Tumors can be quite alive, and their SUV can go down, and so I'll explain more later.
Well, exactly. What does it mean?
No. But if a tumor is FGG avid, I found something you said fascinating, and I'm hoping you can educate me. We're 20 years behind what we can do. So if you just take angiosarcoma stage 3 in the heart, and it really is just a muscle tumor that likes to send off projections, which is why we always use chemotherapy to bring these projections back into the tumor. Is there a way or a technology, because this would actually be the metric, right, where we can combine something like PET with cardiac MRI to find these micro projections so that we can actually figure out when they come back in the tumor? Because it's not size, unless it changes a surgery, that matters. It's when we bring these projections back in. And so is there an imaging modality that exists, that software behind, we can actually push towards so that we can actually use this as the metric as to when to resect?
So I'm not.
Use the mic.
I'm not an expert on the sort of emerging imaging modalities. Certainly, that there's a lot of work being done on the fusion of multiple modalities and what can be extracted that way. In terms of what's coming along, the only things that I'm aware of in the CT world is the dual energy CT, which may give you a bit more information. But if you're primarily relying on MRIs, with the MRIs, it's sort of just a bigger magnet. But I think you need a radiologist to be able to really give an answer to that question. But certainly, if there is an imaging modality that can detect it, then the modeling is technically possible. There may be sort of issues in terms of access to data and vendor compatibility and those things, but the modeling techniques are pretty similar, as long as it can be detected and measured radiologically.
I think I want to ask a question of the people that are here from elsewhere, because I know what's happening in Toronto, is do you use this technology in your centers? The 3D, give him the mic.
Yeah, Reardon does use it, so it's not in our center. It's across the street at Methodist, but
He uses it for the surgical planning.
planning aspect of it.
And what about in your centers? You can ask a question.
So there are research projects looking into various 3D techniques, but we don't use it routinely as a clinical tool.
In St. Louis and Washington University?
We're doing all sorts of weird things, but it doesn't cross into clinical practice because of the malware.
He said, just so it's
I keep
recorded.
trying to give it away. Sorry, one of the neat things about St. Louis is the Mallinckrodt is there, and so not only are they getting into 3D, but they're also throwing all these novel PET imaging tracers into it. And so, you have hypoxia PET, which might be actually much more useful than glucose uptake. You have, port PET, like all of this fun stuff that where if we can show utility development, I often use are there. I think, what's neat about this conference is we can think bigger.
Yeah, I think it's a great opportunity to have collaboration for you. He has a lab called APIL, Advanced Program.
Preoperative Imaging Lab.
Preoperative Imaging Lab.
So I just moved from Montreal, and I'm staff here in Toronto. But in Montreal, we basically use it for radiation oncology. So we have a software license from Halifax, but we also have 3D printing so that we can basically modulate the dose of radiation therapy more personally. Based on 3D printed boluses and catheters so that we can deliver brachytherapy to locations that we want. We are also using it with aortas to basically remodel the aneurysms and to basically guide the surgeons and the radiologists to better visualize and to produce stents that are more appropriate to those effects. There is a laboratory by a radiologist there, Gilles Soulez, who basically looks at the ultrasound and modelize how the blood flow works in the AAAs. And then finally, there is a thoracic surgeon there, Moish Lieberman, who is basically looking at 3D printing using metallic objects to basically look at new novel biopsy devices that can go safely into lesions. So that's how we utilize it.
And what's your area of practice?
I'm a radiation oncologist.
Radiation oncologist. Can I just move very quickly? We have a few minutes left. Can I move very quickly into neoadjuvant chemotherapy. I asked you to give that talk because at the recent CTOS meeting, I looked up the literature about that, and I know how little there is. You spoke about metabolic response, and we've spoken about that at the monthly MD Anderson tumor board meetings. Incidentally, I'm sure you'd be happy for people around the world to join that conference, because I know you're very open to that, and it's very, very beneficial. I've received a lot of information and education regarding that. Can you expand on that a little bit more, and let's see what they think in Toronto and in other parts of the world about that?
Yeah. So so as it turns out, in this particular setting, the reason why we use functional imaging is because of surgical schedules. Because if you do a scan 6 weeks into therapy and find out that 6 weeks after starting chemotherapy, the patient is actually progressing and you need them on the OR schedule, good luck. It is not going to happen. So what we end up doing is that we do a short interval PET CT that gives us a hint as to which direction things are going. And if there is a robust response, we don't have to bother with trying to secure an OR slot, which we would otherwise do if there is some functional evidence that the tumor is actually progressing or remaining about the same. We always ask them to hold a slot so that in case when that 6-week restaging comes around and the patient is progressing, we have the option of actually securing a slot in the OR to move the patient to surgery.
So what's early, 2 weeks?
Oh, it's usually 2 to 3 weeks. We'll typically get it around 2.5 weeks. 3 weeks time point, they'll be starting the next cycle. So right before that is where we will get that, especially in non-angiosarcoma situations where it's super hard to actually tell if the tumor is actually responding or not. Angiosarcomas, I think, reliably have a very high proportion of patients that go into response. So especially if there's symptomatically they are feeling well, we really don't push early imaging. We only do it after 2 cycles, which is at the 6-week time point.
So I guess with regards to PET in Toronto, for us, this is a bit of a learning curve because the timing is always difficult for us. So you might have difficulty getting OR slots, but I think for us getting that PET in a timely fashion is also an issue. The other issue as well for me is usually at baseline. That is where the difficulty is because we're a group that don't believe in waiting lists. So when they get it, when they see us, usually they start within the same week, if not the same day. So the problem is to get all of the workup done in a timely fashion so that you have that baseline to compare with. More than often, I find that could delay me and then, under the pressures of time. But I guess it's a learning curve with us as we know how to use this imaging modality as part of our routine. Probably we'll use a lot more. The saving grace sometimes is these come through the cardiothoracic group, and they usually do PET scans as their standard, and when they come through that pathway, for us it's a lot easier because they usually come with brain imaging already. They come with a PET scan. It is when they don't come through that route, and that usually creates a time pressure for us.
Hi, Abha Gupta. I'm one of the medical oncologists in Toronto and work with Albi, and we most of the time agree, which is really helpful. But my question is actually back at the surgeons. Should we actually automatically offer chemotherapy to every patient with a cardiac sarcoma? Because as Albi mentioned, you're saying yes, in the extremity, and at least in Toronto, we don't do that. And so we really look to you to say, is this resectable safely in an easy way? And if you're my question is, if we are to just give everybody chemotherapy, then that's okay, and then we can always debate kind of what the dose of ifosfamide should be.
I like to be a little contrarian because I disagree with AIM. And it's because it's angiosarcoma. You get a leiomyosarcoma, we'll do all the AIM you want, and I'll push your dose way above 10. this is still angiosarcoma. I find that I always think about the micrometastatic disease. One of the reasons not to operate first is you create metastatic disease. We've learned this cutaneously. We've learned this from every other angiosarcoma. It's because of what it is. And so the whole idea is if you want real R0 surgical margins, I think one of the funny things is when I started this way too long ago, I was told you can't get negative margins even when you have negative margins with angiosarcoma. Now we have people 5 years out because we all started empirically doing chemo first. And so, I think this needs prospective studies, and it's going to take institutions of MD Anderson and Princess Margaret coming together to the volume to do it prospectively. And then randomize between these, because, if most of the time you use AI and then retrospectively look, you're self-selecting people that you're giving Gemtax to, and therefore the response rate's lower. I, on the other hand, have done this for, I never thought AI worked that well for angiosarcoma, and all of my data is Gemtax based. And our outcomes are stellar. And so this is one of these things where this field and this room needs to come together prospectively. And even whether it's registration trials, there's no money here. No one's going to support an ifosfamide trial. No one's going to support a docetaxel trial. But docetaxel and paclitaxel, I use both. I interchange them. It's funny how I've empirically figured out that your 4-month standpoint, I actually switch the taxols and then go weekly when we radiate. And then by the time we're done, we pretty much have close to path CRs that these surgeons are resecting. And so this is where we all, you put 5 sarcoma doctors in a room and you get 6 answers. But I just thought I'd throw that out there.
Really contrary. What does path CR mean? It's very challenging, isn't it? And you're right. We need to move forward, and we need to move forward from the sort of hodgepodge of retrospective studies, and that's why I think it's such a great meeting to try and establish some sort of international database so that we can really sort of look into the even the retrospective data properly. Sure. It's amazing what Alex Gronke has been able to do with the retroperitoneal sarcoma working group, where we've got real sort of insight into the different diseases, even from large retrospective studies. And that, I suppose, in a way, is a starting point with cardiac sarcomas, because looking at the data, it's really difficult to sort of say anything. And certainly for me, anecdotal fantastic responses to AI, it sort of coloured my view on the and biased my view on the topic. I'm getting too philosophical even before my presentation.
No, so. I think it's great. I think this is great. Go ahead.
I just wanted to add that I think we can agree that there is a lot of variability in opinion in moving forwards, which I think sort of leaves an audience fairly confused. While we talk about the utility of the different chemotherapy regimens, which might be better or not, I think it's important to stress that in patients with cardiac angiosarcoma who just get treated by surgery alone, the probability of actually achieving a curative outcome is incredibly small to zero, right? So the onus is on us to actually move that needle forwards with the available tools. How we're going to innovate in order to get there is entirely up to the community to come together and do it. I do acknowledge that there is no magical imaging tool that'll give you the best overall survival connotation to your treatment responses, but I'm trying to use the tools I have at my disposal in order to get to a point that is better than no assessment at all. And I think getting together to study this prospectively is going to be a very critical need that we can all agree on, and maybe put some real actionable steps to doing that. Maybe the database would be the first way of actually beginning to put that data together and starting to.
I think we're all on the same page, and you can sort of go into the nuance of this and that schedule, and what does pathological response mean, but I think we're all on the same page. And I suppose for individual patients, it's a judgment call as well. I particularly liked your comment of don't be too greedy, particularly in angiosarcoma. You know, we stop now and move on to local therapy. So I think we're all on the same page, and I suppose it bringing everybody together to just almost to standardize our evaluation and our assessment of the data would be good.
So may I add to that? I think Robin is right. We are all on the same page. I think we are saying the same things, even in the face of very little evidence, if you like. There's a lot of practice that we have taken in this field without much in terms of data to back it up. So where the database becomes very, very useful is that if we could even identify as a starter, if you like, not with thinking the potential of an international database, if we just look at people who get chemo versus the people who don't, and the people who don't could really have gotten chemo, but just because of practices where they are, chemo is not employed. Because the one of the problem with the selection bias with a lot of this retrospective series is that, you know, especially in institutions that do give chemotherapy, is that those patients who don't get chemotherapy, they're not really comparable cohorts. So even if that database can tease that amount of information, that would actually give us a lot of confidence that we are perhaps looking in the right direction on how we practice managing this disease today.
You know, I think that this is something where this is what the collaborative groups are for. At least through Alliance, there's a sarcoma working group that at least two of us are members of. I don't know if you are. But I think that there's a novelty, not just doing like a surgical sarcoma trial that's kind of boring, but to the NCI, to going after pure cardiac tumors in kind of a randomized fashion to something. It'll establish a baseline, it'll be a small study, but I think this is the only way to do it, and it's a mechanism that we have access to, and then through the network it can open everywhere, and at least then all we have to do is come up with all the funding for the genomics and correlatives.
I was just going to tease you a little bit. Thank goodness you didn't ask me to talk about adjuvant chemotherapy because the audience would be completely asleep. So that's a good thing.
Go. You want to ask? You have to ask into the microphone, though. Just to answer Abby's question, yes, I think that everybody should get it. I've had an opportunity to review all of the world literature about neoadjuvant chemotherapy, and I think that I don't know. I was surprised at how many R0 resections there were without chemotherapy, without neoadjuvant chemotherapy. But I think neoadjuvant chemotherapy identifies those stellar patients that have an opportunity to do well. And the chemotherapy, what it does is it weeds out those patients who will progress on chemotherapy afterwards. Because I agree 100%. This is not a localized disease. I think of it as a systemic disease as well. Yes, we go after the nice thing to cut out, and it's lovely to reconstruct hearts and things like that, but it's a systemic therapy, and I think that if we give neoadjuvant chemotherapy and those people we're able to get a piece of, you know, sometimes in the left side it's very, very difficult, or if the patient has a large tumor, it's very difficult. I think it weeds out those patients, and in fact will improve the outcomes of surgery because we're weeding out those patients who will do very poorly. So I think it's important, yes, to give chemotherapy to everybody before we go and cut them open. That's my feeling about the whole process right now.
So my question for Dr. Rav and Dr. Razak, do you have any experience in giving patient beta blockers during chemotherapy to further tumor reduction, for especially in the angiosarcoma?
So this is where I think there is a big difference of sarcoma of the heart versus sarcoma elsewhere, and angiosarcoma is included in that literature. So, for example, if you take angiosarcoma of the scalp, you have a lot of more data than I do on this. It's a very different animal to angiosarcoma in the heart. The use of beta blocker and vinca alkaloids is based on one study that I know of. It hasn't been reproducible in our hands. I've stopped doing it because despite the promising data, it hasn't worked in our hands. And you know that as well from our perspective. Yeah.
So I think this is one where Robin will have to take ownership for the UK approving propranolol as standard of care on the basis of the experience of, what was that, 13 patients? Because it was cheap and it's probably okay to do it. We've looked at this data a little bit in our set, and it's angiosarcoma in general. So we're stepping out of the cardiac realm. All vascular tumors, when you collect all angiosarcomas together, which is how the Banavelli publication came out as, there is a small survival trend where that curve is slightly above the group that never got any beta blockers. This is, and I have to say this with a fistful of salt here, because it's just looking at it from 30,000 feet view around the fulcrum of yes beta blocker or no beta blocker with all therapies, not just the Vinca, the way in which they actually presented their paper. So there seems to be some modest advantage. It's not entirely mechanistically clear why propranolol actually produces that effect. I'm always leery of areas where, at least if I'm not able to even theorize why it might be happening, that it may just be a random effect that you're picking up in that particular subset. But there is a very small trend in retrospective series that there may be an advantage. We do not use it as standard of care in our neoadjuvant or adjuvant patients unless the patient was already on it for some other reason, which is how we compared the two groups. We said if they have hypertension or another condition that required propranolol, they clearly can't have a better survival. It means they have more comorbidity, so they should technically do worse. So when we run the analysis, there's a small benefit there. But when adding propranolol to already progressing disease in an existing regimen does not work. Been there, done that. And giving propranolol alone in patients who are transitioning out of hospice never works. So the drug by itself is useless. Adding it to a progressing regimen, useless. Does it do anything when there are other agents that clearly work in the disease? It's not entirely clear. And that's basically how we leave that particular compound.
I agree. I mean, I think the evidence base is clearly limited, and even the preclinical data are very limited, and limited in terms of the drugs, the dose, the schedules that are used. I suppose there are sort of caveats in terms of the. I think the French sarcoma group were conducting a prospective trial in combination with the Vinca alkaloids. So, I mean, we can see, but anecdotally, my experience of people who have decided to take it is same as yours.
It's up there with the dog dewormer that we keep getting asked about these days. That's all I got to say.
One of the speakers mentioned that one of the factors that probably makes these more metastatic is the fact that they're being constantly mechanically agitated by the heart movement. So are there any studies actually looking at just hemodynamics or like average heart rate of patients throughout the duration as a predictive factor?
So I think the mechanical agitation probably helps, that you've got it in the pump and it's sending out cells, but I think it's a molecular event, because even in angiosarcomas occurring in the liver, which doesn't pulsate, or in the spleen, they are widely metastatic and have a huge potential. So angios do bypass multiple steps in the metastatic process because they live inside the highway and they are adapted to that environment. So the kind of mutations that are required to turn on capability to dissolve basement membrane, get into a blood vessel, a lot of things gets bypassed in the process. So I can understand why they are metastatic early. We find that even the 5 centimeter cutoff that we standard use for soft tissue sarcomas don't apply to angiosarcomas. The size cutoff below which we have never seen Mets is 2 centimeters. Anything larger than that, we've had cases that have progressed into metastases. So we don't give any chemo for people who are less than 2 centimeters, but anything more than that, we've traditionally, I know the practice is quite different in other centers, but we've really pushed that systemic therapy in those particular areas. But I'm not sure that it has everything to do with the agitation. Clearly, the cardiac ones do the worst. So I'm assuming it does have an impact on it. But even when you look at it at the molecular level, the mutations that drive cardiac sarcomas are very different from the UV light related cutaneous ones from the head and neck region, or the radiation associated ones you get in breast cancer, post breast cancer patients. So there's molecularly they're different. They're not MYC amplified like your post radiation ones from the breast, and the metastatic potential also is quite different. So I would believe that it has a more molecular basis than purely just the mechanical part of it.
And obviously it's multifactorial. I was saying as a potential mechanism for propranolol, for example, having possibly an effect. For example, if there are fewer heartbeats in a 2-year span as opposed to more heartbeats, do you think that could be a contributor to a much more complex picture, obviously?
So the propranolol data is actually mostly from other angiosarcomas. Rather than cardiac angiosarcomas, particularly the one that I just spoke of. So I don't think that even there it is really related.